I've been asked to give this lecture on how to manage the hypotensive patient. The teaching is case-based, so it's quite heavily reliant on interaction from you guys. So if you're able to, when I ask questions, just respond in the Zoom chat. In terms of an outline for the session, we'll start with a really brief introduction. So we're mainly going to be looking at the concept of shock, and I'll explain that. You may have heard of it previously, but we'll go through it, and then also a kind of brief approach to the hypotensive patient. Then the bulk of the meat of the teaching will be centered around 3 cases. We'll definitely do 2, and then as long as we have time, then we'll do the 3rd one. And then we'll do some questions at the end. If you guys, if you guys have anything you want to ask me or need to clarify, then we can have that kind of free space at the end for you guys to direct anything you want towards me. Learning objectives, be confident using a primary survey, kind of airways, breathing, circulation, disability, and everything else approach to assess acutely unwell patients, acutely hypotensive patients. Understand and apply important principles, assessing and managing kind of shocked or hypotensive patients. Appreciate the 4 broad categories of shock. I don't know if you guys got to see the paper that was sent around prior to the teaching, no worries if not, but that's quite a helpful thing to have a little flick through, and also to kind of appreciate the fact that shock can be caused by lots of different things. And that you kind of need to find out what the underlying cause is and manage that appropriately. So when we talk about hypotension, what we're really talking about is cellular hypoperfusion. Someone can be relatively normotensive, have a normal blood pressure, but at the cellular level still be hypoperfusing and their end organs not kind of working properly. So it's better to use the term shock. Shock itself is not necessarily the best term because it doesn't tell us lots of information about what's causing the shock. It's just a term for a broad pathophysiological state, but it's better than hypotension really. Fundamentally, essentially, it refers to global oxygen demand being more than the global oxygen delivery state. That's what shock represents, and that fits with this idea of hypoperfusion. And yeah, I guess it's all in the context of circulatory insufficiency. So global oxygen delivery, if we flick back to this slide, if you try and keep this in your mind, O2 demand is greater than O2 delivery, and that's what kind of a shocked state is. And so when there's some kind of pathophysiology that causes your O2 demand to be really high at the cellular level or end organ level, we need to think about how we can increase the O2 delivery. Hopefully everyone follows that. So we need to then define what global oxygen delivery means. And we break this down into kind of 2 components really. One is cardiac output, and that can be further broken down into heart rate times stroke volume, so really kind of how well the heart is working, and then into the arterial oxygen content, so how much oxygen is actually in the blood, which is then being pumped around the body, and that really is broken down into the oxygen carrying capacity of the blood, which is essentially your kind of hemoglobin, and which is the HB, and then your oxygen saturation is the degree to which that hemoglobin is carrying blood. So that's your SpO2. As you can see, so if we keep this kind of equation in mind, and we flip back to this one, we basically, when oxygen demand is really high, to try and manage that immediately, we want to try and bring up the oxygen delivery. And if this is what global oxygen delivery is, cardiac output times hemoglobin times the saturation levels, those are the 3 things that we really need to modulate to try and increase the global oxygen delivery. And so this slide represents that. Essentially, the things that have the greatest effect on oxygen delivery are, 1, kind of actually increasing, boosting the hemoglobin. The second thing is to increase your cardiac output by increasing the circulating volume. And the third thing is to boost your oxygen saturations. In reality, the top two things, if you gave a blood transfusion, then you would both increase the hemoglobin level, but also increase the cardiac output because you'd increase the circulating volume. But then also whacking some oxygen on them through a non-rebreathe mask in an acute setting would mean that you're able to try and boost those oxygen saturations as well. So those are the three main things that you're thinking about. When there isn't effective global oxygen delivery, you get the thing that we were talking about, the end organ hypoperfusion. Essentially, that means that you flick into an anaerobic state of metabolism rather than the aerobic state, and that's significantly less efficient, 18 times or so more, kind of less efficient, and that generates lactate. So that's just a small note to say it's really helpful looking at lactate, and we always look at lactate in the emergency department generally, and that's what we're thinking about. There's various things that can increase lactate, but one of the main things we're looking for is kind of anaerobic metabolism driving the lactate up, and that's something that's concerning, and then we need to find a cause for that. This is a bit of a busy slide when I pop everything through. This diagram is from the paper that we circulated originally by Standl. Again, no worries if you haven't had a chance to look at it, but I'd recommend it after this lecture as well. Broadly, you can classify shock into 4 categories. So if you see the diagram, it's split into volume and output. So let's look at the top half first. So volume depletion wise, you can be in hypovolemic shock. So either through loss of blood, and that might be overt blood, so you're kind of losing blood because of some kind of stabbing or overt trauma, or internal bleeding, kind of GI blood losses or peritoneal or retroperitoneal bleeding, or it can be non-hemorrhagic or non-blood losses. So that's diarrhea, vomiting, renal diuresis, things like that. The next type of shock is distributive, and that might be some kind of microvascular dysfunction leading to increased vessel permeability. So sepsis is the most obvious example, or an issue with the regulation of the tone of the smooth muscle in the vessels, which is what happens in anaphylaxis. Then in the lower half, we're looking at an issue with output more broadly, and that is split into cardiogenic shock. So that could be an issue with the actual muscle of the heart, pump failure after a big heart attack or something, or if you have left ventricular failure. It can be a conduction system abnormality. So if you have a tachyarrhythmia, then there's not enough time for the heart to fill, and so you're not able to, your cardiac output is affected as a result. And the third might be a kind of a gross valvular problem. So if you have valvular stenosis of some kind that isn't allowing blood to be pumped out effectively. And then the last type is obstructive shock. So that's kind of, if you think about your advanced life support and resuscitation, this is where a lot of those reversible causes come in. So cardiac tamponade, where the heart can't pump properly, tension pneumothorax, where there's compression of the whole circulatory system and it's harder for blood to pump round, or a big P actually blocking the kind of pulmonary perfusion system. This next slide is pretty common sense, but I think it is really useful to bear it in mind, and it's something that I think about every time I go into an acute situation with somebody that's really unwell, or particularly in a kind of shocked state. Is there's 2 concurrent streams of thinking that you need to be keeping in your mind when you approach kind of a shocked patient. One is recognize the degree of physiological compromise. So that's through your assessment, really: heart rate, respirate, urine output, blood pressure to some extent, things like lactate, skin turgor, cap refill, all of those things, and then think about how you want to correct those. So that's the things that we spoke about earlier on. If they need blood, then give, increase their hemoglobin. If you need to increase their circulating volume, give them fluid boluses. If you need to increase the oxygen saturation, then put oxygen on them, those kinds of things. So that's one stream. And then the other is thinking about the underlying driver or the cause and how you can correct that. So that really is, if you think it's sepsis, then to give antibiotics early. And yeah, a really quick note on hypotension and the fact that is not particularly reliable, even in kind of hypovolemic shock. You can lose up to 30% of your circulating volume before you see a change in blood pressure. So it's probably, pre-terminal. It's one of the last things in terms of your vitals that changes when you're in shock, basically. So don't rely too much on it. So case one. 80-year-old gentleman, so you think about this, you're in the emergency room, the A&E department, and an 80-year-old male is brought in by ambulance. He's had a syncopal episode today, basically means he had a fainting episode. He lives in a nursing home. He has a background of some dementia and poor mobility anyway, but his nursing home staff or carers reported that he had some sudden onset sharp chest pain, when he fainted earlier, and he'd been complaining that his arm was also hurting, quite non-specific. By the time the ambulance had brought him in to hospital, he was pain-free and he was actually really comfortable, just relaxing. But staff have said they think he's a little bit more confused. He has a background of dementia anyway, so it's quite hard to tell, but they think he's more confused. Background, he's got hypertension, for which he's on various antihypertensives, ramipril, atenolol. He's also hypercholesterolemic, so he's on a statin, and he's a smoker still. And I'll give you the initial observations. So when somebody comes in, obviously they get triaged, and so they'll do initial set of vitals. So there you see nothing very exciting. He is slightly tachycardic, but there's nothing else obvious apart from that. I mean, you could argue, and this is a learning point, that his blood pressure looks okay there, but that's in the context, it's 120 systolic, but he's on ramipril and atenolol. So yeah, that's probably, and he's normally hypertensive as well. So again, not that helpful looking at the blood pressure. How do you interpret that in the context of the fact he's hypertensive normally, but he's on these blood pressure medications? So what are your first thoughts? What's your differential diagnosis? What do you think is going on here? If we move on, yeah, I agree. I think that the most likely diagnosis based on the information you have so far is some kind of acute coronary syndrome or stable angina. Also, you want to think about aortic dissection. He's had a bit of sharp chest pain, but it's difficult. I agree. Chest pain, arm pain with cardiovascular risk factors, ACS is the first thing that you think of. Tension pneumothorax, it could be. Sharp chest pain, again, PE, sharp chest pain, no real shortness of breath or other respiratory symptoms though, so those two don't massively fit. And something to always think about, particularly an elderly male, is has this person had a ruptured AAA? Someone really accurately said earlier on, ISRA, that the patient's hypotensive relative to his usual blood pressure. I completely agree. So 120 is actually low for this patient, so you'd probably be a bit more worried, and that's probably why he's also a bit tachycardic as well. So initial assessment. What are you going to do? What's the first thing you're going to do? I'd start with, so ECG is absolutely right, it's really important, but you want to do an A to E assessment properly to get a better idea of what's going on next. So let's start with that. A, the patient is maintaining their own airway. B, chest is clear. So by A, I mean airway. B, breathing, chest is clear. His saturations are all right, but he's a bit tachypneic. He's breathing a bit fast. So there's something going on. He's got an ejection systolic murmur, and he's peripherally shut down. So his circulation isn't great at the moment, but his blood pressure has crashed. So it's 70/30 now, and he's really tachycardic, 135 beats per minute. GCS 14 because he loses a point because he's a bit confused, but his pupils are equal and reactive to light, and his abdomen's soft. There's no surgical kind of picture there. He's apyrexial. In terms of other things that you want that might be helpful, like I said, we almost always look for a lactate. So we do a venous blood gas. He's slightly acidotic, and his lactate is 5, so it's definitely raised. So we're worried there's something going on here. There's something causing hypoperfusion. We do a quick kind of bedside ultrasound scan, and that shows a pleural effusion on the left, or what looks like a pleural effusion on the left side. There's no AAA in his abdomen, so we can kind of rule that differential out. So what now? This person is crashing, that they're really, really unwell. Do you guys want to put, so I know you put, lots of you put ECG, but that was before I told you that the patient is completely unstable. Great, okay. So we've got Saeed saying IV access, absolutely. Intravenous fluid, anything else you want to do? Great, absolutely, yeah. So you want to send some blood tests off. Yeah, pop some oxygen on, that's always going to be helpful. Generally, he's saturating okay, but anything else at all? So yeah, so you might think about PCI potentially. We need to be sure. Yeah, aspirin, yeah, something that you want to think about. Chest X-ray definitely helpful. So you might get a portable chest X-ray gauge. So lots of good suggestions. Yeah, check his central venous pressure, absolutely. You can give some nitrates, cross match, yes, absolutely. Mona, yeah. So that's kind of more ACS. And blood gas test, absolutely. So we did a venous blood gas. And analgesia, again, really, really important. That's something that's mega vital not to forget. So well done, Amjad. So in terms of what we want to do next, I think number one, you want to stabilize the patient, right? So if we think about the 2 tracks that we were saying, one is correct the physiological deficit, and that's what we need to do first. Is we need to stabilize the patient. So you need to escalate to a senior. So we're junior members of the medical team. You need a senior member of the medical team there. This person is completely unstable. You need to find an underlying cause, sure, but you also need to think about getting big cannulas in, giving them a huge fluid bolus to try and bring their blood pressure up. It looks like this patient might be losing blood from somewhere, so you might think about giving some blood. ECG, okay, so lots of people ask for ECGs. There's some mild ST depression in the lateral leads, but there's no raging ST elevation, nothing that suggests that necessarily this is a big cardiac event that's going on. Blood tests, so yeah, your basic blood tests, including your cardiac enzymes, you want to group and save. This person is decompensating with a crashing blood pressure. You need to be able to give them blood quickly if that is what's causing their hypotension and decompensation. Portable chest X-ray actually didn't show anything, so it's a good thought, and it can be really helpful. Show kind of a big tension pneumothorax or a few other things as well, but nothing on there. CT angiogram. So I know it seems slightly maybe contrived, but in this context, with someone who has had sharp, sudden onset chest pain with involvement of their limb, they've become newly confused. They have a new murmur and a rapidly dropping blood pressure in someone with also the risk factor of hypertension. My top differential, especially in the context of the ECG not being very exciting, is aortic dissection. This is how that presents. It's an incredibly commonly missed diagnosis that's really bad and fatal if we miss it. So it's something to really keep in your mind. And even if they might be having a concurrent MI, you want to manage the dissection first, right? If you think that is what's going on, a sharp chest pain that's not exertional is less typical of an MI, really. So you get a CT angiogram, and it shows an aortic dissection, like we thought it possibly might be. What are you going to do now? What are the next steps? Yeah, really good point, Said. So you're let's say you've given a couple of units of blood, and his blood pressure is coming up a little bit now, so he's slightly less tachycardic, and his blood pressure has come up to 100, but it's still bad. He's still unstable. Yeah, definitely under call for help. Absolutely. Surgical intervention. A couple of people have said. Malak has said. For sure, I agree. Abdallah has said as well. Cool. So yeah, all good and important and correct suggestions, right? So there's four things really. If once you have the sure diagnosis of a thoracic aortic dissection, there are four key things you need to do. Number one, you need to get a cardiothoracic opinion. They are the people that are going to be able to tell you what needs to happen next. Does this patient need to go to surgery or not? From the pictures, the radiologists will be able to tell you whether this is, well, the most commonly used classification system that largely impacts our management is the Stanford classification system. So that divides dissections into type A and type B. Said, you're completely right. Hold that thought. So type A essentially is the dissection that involves the ascending aorta and the arch, whilst type B is distal to the origin of the left subclavian artery, so the kind of descending aorta. Type A, generally open surgery because you need to prevent rupture into the pericardial sac and tamponade. Type B, largely it's medically managed. There's some exceptions. I've put it in my notes in my presentation, which you'll get afterwards. But yeah, we won't go into that now. So that's number one. That's the most important thing that you need to do. Number two, control the pain. So intravenous opiates, do not kind of sit on that. Don't not do that. That's really important. And someone earlier on said, control the chest pain, and that's what we're thinking about here. It also has an impact on your sympathetic response, which you want to control as well. So by bringing down the pain, you help with that as well. Number three, yes, Said, you said beta blocker has a role now. Absolutely. You want to titrate their blood pressure and you want to titrate their heart rate, not to extend the length of the dissection and worsen the problem. So here, first line in the UK, we use IV labetalol and you titrate that. But yeah, there's various agents that have a role. And then the last one, which is really important, and maybe they generally wouldn't be in the textbooks, but ceiling of care. You need to think about this gentleman is 80 years old. He has a background of dementia. His physiological reserve is very low. What is he going to survive? Is it appropriate to put him through all of this? Should he have a do not resuscitate form? Should we be doing surgery on him even? Is he going to survive intensive care? Is he going to tolerate that? And is he ever going to leave intensive care, or are we going to ultimately have to call it after the surgery anyway? In which cases, was it not all a waste of time and not very dignified for the patient? So that's all important things that we need to think about. Lovely. So some quick notes on aortic dissection. This is something more that you guys can read up on, but as you can see in the picture, there's kind of the tunica intima, which is the innermost layer, which has endothelium and subendothelial layers of connective tissue. There's a tunica media, which is the middle layer. That's more the elasticity and strength. And the tunica adventitia, which is the outer layer, that's largely collagen, and then it also has the blood vessels to the blood vessels, i.e. the vasa vasorum. We're interested in a nick or damage to the tunica intima, and that's really how the dissection then tracks down. In terms of a history, so demographic-wise, risk factors, the most important ones are hypertension and connective tissue disorders, so Ehlers-Danlos, Marfan's, that kind of thing you'd look for in the actual physical examination, and background. History, really, it's the subarachnoid hemorrhage of the chest, right? So if someone has relatively sudden onset chest pain that's tearing or sharp and very severe, and particularly if it migrates up or down into the limbs, it might stop. That's something that's worth bearing in mind. If the dissection has stopped progressing, or if there's kind of relief of pressure of the aortic wall because there's some spontaneous re-entry of blood back into the true lumen rather than the dissected lumen, then you might, the pain might stop. That doesn't mean it can't be an aortic dissection, right? And the other thing I've written is, remember chest pain, CP+1. That's another rule which you can Google, and I've written in my notes as well. But if you get chest pain with another symptom like stroke-like symptoms, some kind of paralysis, hoarseness of the throat, or limb involvement, limb ischemia, you want to think, is this person dissecting, and have they thrown off their arterial supply to some of their other organs? Is that why they're presenting like this? On examination, check for pleural effusion. You know, we saw on the bedside ultrasound scan, he had a pleural effusion. Actually, that was a hemothorax because of blood bleeding from the dissection. And there's lots of reasons why they can be hypotensive. So it can be hypovolemia through, you know, blood loss into the, you know, a big hemothorax, or into the false lumen. It can be due to pump failure, so hemopericardium leading to tamponade. It can be, you know, a secondary myocardial infarction, or an MI because the coronary arteries have also dissected off. Or it can be complete heart block following kind of hemorrhage into the intra-atrial septum, disrupting the conduction system. So lots of reasons why they can have hypotension. Investigation-wise, yeah, ECGs, often you see non-specific ST segment and T-wave changes, so not that helpful, really. Portable chest X-ray, you know, you might see a widened mediastinum, you might see loss of the aortic knob. I'll show you on the next slide what I mean by that. But really, even if that's normal, that is not good enough to exclude a dissection. You need to get a CT angiogram, and this is what I mean. So I don't know if you can see here, but kind of yeah, what a normal aortic notch, it kind of goes in and then back out again here, whereas in a dissection you kind of lose that totally. Brilliant. So take home messages. One, and someone said this earlier on actually, and I was really impressed, is, you know, someone asked what's the blood pressure now? Yes, that's really important to constantly reassess hemodynamically. I'm not completely sure, Abdallah, what the normal diameter is on a chest X-ray. I'll have to look that up, but yeah, I can pop that in the notes or in the email that goes around afterwards. Take home's regular reassessment. That's really important, and kind of rule number one of the emergency department is the patient is constantly changing. It's dynamic as a situation. Number two, yeah, the aortic dissection pain can resolve. And number three, it's really easily missed. So if you think of or see any of the things that I mentioned, sudden onset severe sharp tearing chest pain, especially if it goes up or down to the limbs, or the whole chest pain +1 presentation, always have it in your differential list. And there's some really great reading and resources there, so it's worth clicking on those. You'll get the slides afterwards. You're absolutely right, Said. Yeah, the difference in radial pulses, there's a difference in blood pressure in arms, all these things. But the reality is, in a clinical context, you don't always see that. That's only when things are really bad. Patients don't typically necessarily present with that. Fewer than 50% of cases you see a difference in the radial pulses and things like that. So you're completely right, but it's not reliable enough, which is why I intentionally didn't talk about it. Fab, there we go. Great. So case 2, a 63-year-old female. They were brought in by their partner with severe lethargy, so really tired. They've had a fever for the last couple of days, and they're pale. You know, they've lost all their colour, and they're clammy, a little bit sweaty, a little bit cold. Past medical history: they have breast cancer. They had a mastectomy 6 weeks ago, and unfortunately, possibly because they have bone metastases, they had a fragility fracture where they fractured their hip, and so they had a total hip replacement 4 weeks ago as well. The drug history-wise, they're on a chemotherapy regimen. Triage: they are tachypneic, they're breathing fast, saturations are okay, but they're tachycardic, and already they're hypotensive at 90/60. Normal blood pressure for them is 110, 105, so it's not super hypotensive, but it's, you know, they're tachycardic and hypotensive, and they're pyrexial, they have a fever. So first thoughts, top right, there's a little bit of a summary of the presentation. What do you think is going on? What differentials are you thinking about? Great. So we're getting lots of good answers in. Yeah, P, septic shock, distributive shock, absolutely. Any other thoughts? Infection, yeah. Yeah, good thinking. Long bone fracture, fat embolism, for sure. Great. Okay, so yes, I agree. I think it seems largely people are saying sepsis, septic shock, and a few other also important things that you need to think about. Yes, maybe right-sided heart failure. Sepsis, it's got to be your number one thought. And the second question really is, where is it coming from, right? So this is a patient who has active malignancy and they're being treated with chemotherapy. So your absolute top diagnosis has to be neutropenic sepsis. Absolutely right, Jomana. So differential wise, number one, neutropenic sepsis, and here you're thinking about the source. That's really important. It might be due to a line, so that she's having active chemotherapy. She's going to have some kind of a central, something like a Hickman line or a PICC line in. So it might be from the line. It might be a surgical site or joint infection. So I've just written things commonly that you might see, which I'm sure you guys are already familiar with. But so if it's a line infection, you might see pain around the site of the line insertion. Surgical site or joint infection in the hip, you will see oozing. You'll see kind of discharge from the site of the closure, dehiscence of the wound is coming apart, pain on moving the joint, and then obviously your kind of other common sources of sepsis, so chest, urine, GI, and skin sources. Or it might be an unknown source of sepsis, which we'll come to as well. But your absolute number one, even if you're thinking a little bit about your the other few things that were mentioned, P is also important to think of. You might end up scanning this patient as well, doing a CTPA on them if their well score might hit high, but they don't really have shortness of breath. There's no well, let's look at the numbers quickly. Yeah, there's no kind of shortness of breath. There's no decompensation in terms of their saturations. They're tachycardic and they're tachypneic, which might be enough really. And yeah, there's not really any chest pain either. But you're absolutely right. The guys that said P, yes, you might think about doing a scan for them. But the main thing you need to think of is neutropenic sepsis. That's the number one thing. Other causes of a raised temperature and kind of this kind of presentation, it might be another underlying malignancy, kind of a non-solid malignancy, some kind of a blood cancer. Immunotherapy related toxicity can also present like this, less likely to be so severe. And also an inflammatory condition flaring up, so an undiagnosed background of lupus or something like that. But it's all quite small print. Really, this has got to be absolute barn door neutropenic sepsis diagnosis. So the immediate thing you're going to do now is, of course, as we said last time, what's the first thing that you have to do with someone that's unwell acutely, that's decompensating in the A&E department? If you write in the chat, yeah, absolutely, yeah. So you want to do an ABCDE approach, totally. And I know this seems like something that, I don't want to belittle you guys, but it's what we do every single day. And I didn't really realize until I started working and I graduated. But, in an A&E department, your approach is always, even until, when you become a consultant 20 years from now, that is what the first thing is that you're going to be doing. So number one, patient is maintaining their own airway. So we're happy with A. B, the really labored breathing, chest is clear to listen to. So maybe not a chest source of sepsis. They're breathing okay, but you pop a little bit of oxygen on just to top them up. And they're breathing a little bit fast, respirate at 25. Heart sounds are normal, peripheries are cool, they're shut down, blood pressure is dropping even more, 85 systolic, heart rate is going up 135 beats per minute. GCS 14, she's becoming a little bit more drowsy, a little bit confused and disorientated, but the pupils are equal and reactive to light. Abdomen is soft, non-tender, there's no surgical type picture, but they're pyrexial and the temperature is going up. It's 38.1 now. Venous blood gas, really acidotic, lactate of 5.5. You're worried. This patient is sick. What immediate steps do you want to do? What's absolutely the main things that you need to do for this patient straight away? Brilliant, brilliant, brilliant. Okay, so lots of people saying really sensible things. So the most common answer has been antibiotics and intravenous fluid. So you're completely right. Your next step is going to be stabilize the patient. Have you guys heard of the SEPSIS 6 at all? So it has its criticisms, but it's really, really helpful as a framework for remembering the important things that you need to do as soon as possible, ideally within 1 hour of recognizing the risk of sepsis. Okay, so they are 3 things. So I remember it as 3 things in and 3 things out. Okay, so the 3 important things you need to administer are intravenous antibiotics as per the local guidelines, absolutely like you said. Number 2 is intravenous fluids, because they're kind of intravascularly deplete. So it's a distributive kind of shock. The issue is a microvascular increased leaky capillaries, but you need to fill them up again properly. So you give intravenous fluids. And the 3rd thing is oxygen. You want to titrate and top up their oxygen. If you think back to the global oxygen delivery equation, IV fluids increases the circulating volume, and oxygen tops up the saturations. And the 3 things that you want out are blood cultures. So you're absolutely right. Ideally, you want to do that, if possible, before the antibiotics. But if it's going to delay giving antibiotics, then it doesn't matter. Get the antibiotics in. That's the thing that has the most evidence shown for altering morbidity and mortality in a septic patient. And then the 2nd thing you want out is to measure their fluid balance. So you want to put a catheter in to look at their urine output. Number 3, their lactate level is a really great way, again, like we mentioned already, of tracking their progress, right? A few other things, some people have been talking about vasopressors, kind of noradrenaline, norepinephrine, things like that. You're right to be thinking about that, and that might be something that will be required at a slightly later stage, but in terms of the very first things that you want to do for the patient, these are the 6 priorities. Number 2, there still isn't a completely clear history. So you maybe want to speak to some other people, speak to the next of kin, the other family members who might be listed that are happy to be contacted, to have an idea of exactly what happened, so that you can maybe figure out, it might be that she'd been complaining of, you know, it's painful when she passes urine, there's burning, there's dysuria. Okay, then you would think, actually, yeah, maybe this is a urosepsis, or actually they might have said she was really short of breath and she was coughing lots in the last few days. And that might lead you to chest sepsis. So that is really helpful, thinking about a source, if you're able to clarify the history. And given she's confused and has a reduced GCS, you need to speak to someone else that knows what's going on. Bedside-wise, urine dip would be really helpful. So when you put a catheter in, the first bit of urine that comes out, you could dip that, that's fine. ECG would be helpful to see, has the sepsis flicked them into new fast AF? Do you need to do anything about that? You know, they're running at 135 beats per minute. Laboratory-wise, absolutely. So bloods and cultures, and this is really important. You want to think about culturing the line. If you think you'll have a strong suspicion it's a line, then you might think about taking the line out and swabbing the line, and then needing to put a new line back in. Also urine culture, stool, if you think that there's any DMV, sputum if there's cough, surgical site swab if you think that's what's causing it. And then the other things are some imaging. So portable chest x-ray is always helpful. You might think about more specific investigations, but generally won't be in the emergency room that you do these. Reassess regularly. So just to reiterate that, we said that last time. Contact the parent team, right? So this patient is a cancer patient. The people that will be best placed to admit her and consider how to manage her in the short, medium, and long term, in terms of antibiotics, in terms of altering other medications, immunosuppressive medications, chemotherapy, all of that kind of thing. It's the oncology or the heme-oncology team, whichever is relevant, that will be able to help the best with that. Number 8, contact the critical care team early. This patient is young, they're otherwise well, with really, it's a single organ kind of issue that they've had previously, and now they're decompensating. So you want to think about contacting the critical care team if they are going to need things like vasopressors. That's not going to be able to be done in the A&E department or on a normal ward. They might need intensive care or high dependency unit care for that to be able to to be managed. So contact the critical care team and just let them know. That is a really nice and useful thing to do. And again, ceiling of care discussions, it might be that this person has stage 4 widespread metastatic cancer. The prognosis is 2 months to live, and then you would think about what is appropriate to do for this patient. How aggressively would you treat them? Would you be ready to intubate them, to take over ventilation, admit them to ITU, if actually that's not what they would have wanted? Okay, so these are all important things that you need to decide and figure out early on. Management-wise, a lot of it we've covered already. Mainly it's about localizing the source and treating. So as per the body system, there'll be microbiological sensitivities that you get back from the cultures. Line, you might, like I said, want to take the line out. If it's a wound, the hip that we think is a problem, you might want to open the hip up again, wash it out, replace either the liner, so often you can replace just the liners, so the contact points in the joint replacements, or you might need to revise the whole joint, so take out the whole prosthesis and put a new one in to be sure that it's clear. Also worth reading about early goal-directed therapy. There's a Rivers et al. Paper from 2001. Lots of people talk about early goal-directed therapy. It's actually now a disputed thing. Basically, it means aggressive fluid resuscitation and invasive monitoring early on. But I've put the link in the extra reading, so have a little flick through. Sepsis. Okay, so I'll give you a quick rundown of sepsis. Definition, so we've moved away from the idea of a systemic inflammatory response syndrome, SIRS, and instead we're now using the idea of life-threatening organ dysfunction caused by dysregulated host response to an infection. And specifically septic shock is that, but in the context of profound circulatory, cellular and metabolic abnormalities, all of which are contributing to an increased risk of mortality. So specifically, they're talking about sepsis plus persistent hypotension and a lactate level which is higher than 2, despite adequate fluid resuscitation. So an ongoing and serious high acuity situation. This, in an emergency department, I've not actually seen this used, but I think probably more in an intensive care setting, it's relevant. The SOFA criteria, the sequential organ failure assessment kind of criteria, is what they use to score the degree of organ dysfunction. So you can see it's broken down into respiratory, kind of your clotting dysfunction, liver, cardiovascular, your CNS, and your renal system. Specifically, neutropenic sepsis-wise, it's an oncological emergency, right? It's the commonest life-threatening complication of cancer therapy. There's this definition. I've put the reference in as well, but it's a single measurement, so it's pyrexia, and also a neutrophil count that is very low, so less than 0.5 is what we say here, but yeah, less than 500 cells per microliter, or expected to become very low in the next 48 hours. This is really vital, right? We spoke more broadly in sepsis about finding the source, but in a third of patients, only less than a third of patients, cancer patients, we find the actual pathogen or sensitivity. So it's more important to find what you think is the source based on the clinical history and examination. Most commonly, actually, it's caused by endogenous flora, because this patient is immunosuppressed, obviously, but you want to treat it empirically based on the history and the examination. You won't necessarily get sensitivities from neutropenic sepsis. And then you need to think about outpatient versus inpatient management. That's the other big question. Can you send this patient home? Because hospitals are dangerous places for immunosuppressed people. If you can manage them at home safely, then and bring them in for intravenous therapy, that's much better. So there's various scoring systems for this. Take-home messages: act fast. Early recognition and management is really important, especially intravenous antibiotics. Consider all different sources of infection. Those are the two main things, really. How are we doing for time? So I'm going to be really quick, if that's okay, and just squeeze in this last case. It's not very complicated, as long as people are happy with that. I'm sorry, I'm rushing. I would be happy to stay a bit longer, but I need to, I'm actually got a shift straight after this, so I'm a bit rushed. Case 3, so a 45-year-old, they have been brought in by ambulance, that's what BIBA means. They were out running in the cold, and then suddenly they couldn't breathe, they felt a bit clammy, they said. They're not sure, they think maybe they were stung by some kind of insect, maybe a wasp. The partner is in with her, and he says that she often has panic attacks, and he thinks that this looks like she's having a panic attack now. Past medical history, anxiety, childhood asthma, hay fever. She's on sertraline, no known allergies, no known drug allergies, no known other allergies. At triage, okay, slightly desaturating, 93% on air, slightly tachycardic and a bit hypotensive, but you know, a young fit woman, 87, it might be, it could be not that abnormal for her. Sorry, so a couple of questions. Is there a role for norepinephrine in septic shock and when to give it? There is a role insofar as its use as a vasopressor to control the blood pressure, but that's in an intensive care setting. It doesn't form, it's not part of the role of the initial management in the ER. So it's only after you've given antibiotics, you've given fluid boluses, and you've done kind of thorough fluid assessments and looking at all of that, that yeah, sorry, I'm talking about the previous case, that it's worthwhile maybe thinking about norepinephrine. So in answer to your question, fine. So back to this case. So yeah, we're a little bit worried. 45, it's a bit non-specific. Maybe it's a panic attack. We're not really sure. First thoughts. Do you want to write what you think is going on? So yeah, getting some anaphylaxis. Anything else at all? You're completely right. Yes, I would also think anaphylaxis top differential. Anything else that you also want to think about? Yeah, maybe an abnormal presentation of ACS is less likely, really. Doesn't really fit. Yeah, absolutely. Panic attack, it could be neurogenic shock. Yeah, possibly. Okay. Lyme doesn't really present like this. Good thinking, but yeah, no, it doesn't really present like this. Respiratory alkalosis. Yeah, I guess in the context of hyperventilation. Yeah, asthma exacerbation. That's the main other thing I was thinking about, really. So anaphylaxis absolutely is a top thing you want to think about. Differentials, anaphylaxis, acute exacerbation of asthma. She had childhood asthma. She's atopic. She's gone out running in the cold. All of those things can trigger an acute exacerbation of asthma. So kind of bronchospasm. And then, yeah, 3, panic attack, angioedema as well, potentially. Fine. So what you're gonna do next? What's the immediate next step that you want to take? We've already said it in both of the previous cases. I'm just trying to make a point. The first thing you want to do, yeah, absolutely, yeah. So do an A2E assessment. So A, stridor, you can hear there's an inspiratory noise when they take a breath in. They're struggling to speak. B, there's an audible wheeze when you listen. It's really labored breathing. The chest itself is clear apart from the wheeze. They're saturating now okay on a little bit of oxygen and they're slightly tachypneic. Heart sounds okay, again peripherally shut down, but blood pressure is starting to crash. They're deteriorating in front of your eyes in the 5 minutes that they've been there with you. Heart rate is starting to race, 140 beats per minute. GCS starting to get slightly less coherent, but pupils equal reactive to light. Abdomen is soft, she's afebrile, but there's some facial and lip swelling. The patient's really getting panicked and she looks worse. And she's starting to develop this rash you can see at the bottom of her neck and the top of her chest. VBG, not very exciting. What now? Great, so some people have already said IM adrenaline, absolutely. Anything else? Yeah, IV access, definitely. Epinephrine, absolutely, absolutely. Fine, so. Stabilize the patient. Treat immediately, and you're absolutely right, you want to give epinephrine. So I've written adrenaline, it's just the same, it's the same thing. 4 things really, but the absolutely top most important thing that you want to give is intramuscular adrenaline. So where do you actually give IM adrenaline? This is worth remembering. So you guys all knew that it was adrenaline that you need to give, or epinephrine that you need to give, but in the anterolateral thigh is absolutely right. And why do we think anterolateral thigh instead of anywhere else? So the main reason really is because it's really well perfused, and you get a far greater serum concentration compared to if you put it anywhere else. So if you put it in the arm, in the deltoid, for example, it's the actual diffusion and it reaching the necessary levels of serum concentration are much slower. So absolutely, yeah. So the fact that it's well perfused, there's big vessels that are whipping it up, that taking it to the place that it needs to be taken, compared to kind of a smaller place. And then there's a role for chlorphenamine, so antihistamines, and also a role for steroids. They're debated. We still give them, but there's some papers that say yes, actually no, it doesn't. The evidence is not that strong. So I've included a few of those papers and those discussions in the extra reading. So stabilize the patient, do the things that we said. The other thing is mast cell tryptase is helpful, and it's a level of a enzyme that's released, kind of an immunological enzyme that's released. You normally do it 1 hour afterwards, 6 hours afterwards, and 24 hours afterwards, but 1 hour after is probably the most important time to do it. A VBG again is helpful. And then, yeah, management-wise, admitting for observation. So we here usually admit for 6 hours. Again, there's extensive debate amongst the kind of the team, the kind of emergency medicine community as to what the point is of admitting for 6 hours. Really, you admit to in case there's a second kind of surge, or there's a delayed reaction, right? Delayed hypersensitivity reaction. And kind of, they call it like a second peak, and that it can occur anywhere from 10 minutes to 2 days afterwards. So yeah, keeping them for 6 hours is relatively arbitrary, to be honest. There's a few reasons why you might admit for 24 hours, but really it's useful to get them an outpatient follow-up or referral to be seen in an allergy clinic, and provide them with an EpiPen and provide them with adequate training to both them and their next of kin as to how to use it. That's the single most useful thing that you can do to prevent mortality. IV adrenaline, really rarely use it in this context unless you're completely and totally sure the time that it takes to draw up and administer, to get access, all of these things, and the risks involved with using intravenous adrenaline mean that it's much rarer that we use IV adrenaline. Yeah, I mean, arrhythmias is one thing that it can throw you into, but yeah, you kind of worry about circulatory collapse and complete shock and decompensation. So yeah, a bit of background around anaphylaxis really quickly is, so definition wise, it's a severe hypersensitivity reaction that generally, so not always, but generally includes the speed of onset, so it's sudden onset. The second thing is there's life-threatening airway or breathing or circulation issues. And the third thing is nearly always you see skin or mucosal changes. That might be lip swelling, tongue swelling, some kind of rash, facial, chest, back. It is really variable. Urticarial changes. Largely, we classify them into immunological, so it's IgE-mediated hypersensitivity reactions. That's a type 1. If you learn the 4 different types of hypersensitivity reaction, it's the type 1 hypersensitivity reaction. I've included a link to a YouTube video that's really beautiful if you're interested, that kind of shows the cellular level, kind of mast cell degranulation and all of that goes on. Number 2 is non-immunological, which is less well understood, but presents almost in an identical fashion. So we call that non-IgE mediated hypersensitivity reaction. And 3 ones that we totally unable to explain, and that's idiopathic, really, really small number of cases. Pathophysiology, we kind of touched on, but it's a type 1 hypersensitivity reaction with mast cell degranulation and the basophil activation. So 3 main areas that this has an impact on is increases the bronchial smooth muscle tone. So you get the kind of bronchospasm, which causes the wheeze, the shortness of breath, the feeling of not being able to breathe. Second is decreased vascular tone, so kind of the flushing and the hypotension associated with it because of peripheral loss of peripheral vascular resistance. And third is increased capillary permeability. And again, that relates to kind of the hypotension. So you get third spacing, you get distributive shock, and the rashes. And that's some reading and resources. You may absolutely need to intubate the patient to avoid airway obstruction. If there is concern, Abdallah, so even if there's not a C issue, so it's cardiovascular collapse, but there's concern of an airway or breathing issue, yes, you would give epinephrine. IM epinephrine is safe, very safe. So even if it turns out not to be anaphylaxis, it's okay. So you would have a low threshold to give IM epinephrine. And that's it really. Thank you so much for your time and your patience. I know I overran timing wise a little bit, so I'm sorry about that. We don't have a huge amount of time for questions just because I start my shift in about 15-20 minutes, so I need to run off. But I really, really appreciate the opportunity. It's been a real pleasure. Thanks so much for, there's no contraindications, sorry, there's pretty much no contraindications to using IM epinephrine in anaphylactic shock. So that's a really good question. Good luck with your exams, good luck with your studies and everything. And yeah, take care. And yeah, if you have time to fill in a feedback form for me, just so that I know, what is helpful for you and what isn't helpful for next time, then that would be great as well.